Okay, and there's Angel. All there. Sanders. Okay, so this is just a good way to understand electrolyte imbalances. There's actually going in and out, but I'm here. Okay. Yeah, I know it's gonna be, we're gonna get some rain today. I just saw on the forecast. So if you go in and out, just try to get on as soon as you can. Okay. Let's see. So I'm going to go to my whiteboard here. So this is going to be a way to get you to understand the signs and symptoms of the four major electrolyte imbalances that we have. So we have potassium, sodium, calcium, and magnesium. Okay, that's going to be the four big ones that I'm going to really want you to know. Like I said, phosphorus and chloride, not so much, because they follow calcium. So the four big ones: sodium, potassium, calcium, and magnesium. So I'm going to go to my whiteboard. Let's see. Share screen. Go to a whiteboard. Okay. Clip. All right. All right. Can everybody see the whiteboard? Okay. All right. All right. So I'm going to move this. Can I move this up? Yeah, that's good. Okay. Actually, I want to make this bigger. Okay. All right. So I'm going to draw, like I said, not the greatest drawer here. Okay. Let's see, draw. So I'm going to make chart. Come down. Here. Yes. Okay. Do that. Do this and this. Down here. Chat. Let's see. Somebody's chatting. Let's see who's chatting. Jordan's here. Okay. All right. Okay. All right. So make this bigger. All right. So these four blocks, okay, these four blocks are going to represent where the electrolytes are being balanced. Okay. So the first organ we're going to talk about is the parathyroid. Okay. Parathyroid. Okay. So what's balanced in the parathyroid, okay, whoops, is, come on now, draw, okay.
Calcium.
Calcium, that's correct. Calcium and phosphorus is going to be balanced in the parathyroid, okay. So calcium, and remember, when one's up, one's down, okay. Okay, so this is the only thing I'm going to really need you to know about phosphorus, okay, is that it's balanced in the parathyroid, okay? So if one goes up, one goes down, vice versa. And if something happens to the parathyroid or the thyroid in that matter, then everything's screwed up, okay? Because it's not being balanced properly, okay? So this is the balance here: calcium and phosphorus. Okay. All right. So then you have the next balancing organ you have is the kidneys. Okay. So does anybody remember what's balanced in the kidneys?
Sodium and potassium.
That's right. Sodium and potassium. Okay, very good. So sodium again, and it goes on that seesaw method. Okay, sodium and potassium. Okay, so in the kidneys, if sodium is up, potassium is down, same thing. Okay, that's how the kidneys balance. Okay, and then our third organ that we have is the heart. Okay. So what do you think, knowing what you know about the heart and electrolytes, what do you think is balanced in the heart?
Potassium.
Potassium is one for sure, correct? Okay, correct. Yep. So potassium and calcium is going to be the other electrolyte. Okay, that's going to be balanced in the heart. So potassium and calcium are going to be balanced in the heart. Okay. All right, and our fourth one that we have, our fourth organ, okay, what kind of organ tissue, okay, is going to be the muscle, okay? So there are two particular electrolytes that are balanced in the muscle, okay? And that is going to be magnesium and calcium, okay? But it's going to be a really subtle balance, not going to be a whole big balance, okay? Because calcium, magnesium, like I said, is going to follow calcium, okay? But the muscle still kind of balances them out, okay? But like I said, it's really subtle. It's not a big balance, okay? Let's see. So calcium, oh no, magnesium's going to be down here. It doesn't really matter where they're at. And then calcium is going to be up here. Okay. All right. So we're going to change the fonts on these. Hold on. So you guys can change the, oh, come on now, text format. Oh, it won't let me do it. Okay. Okay. I wanted to change the color, but it won't let me change the color. Nope. Sorry. Okay. All right. So these are the organs or the tissues where the electrolytes are balanced. The parathyroid is going to balance out the phosphorus and the calcium. The kidneys are going to balance out the potassium and the sodium. The heart is going to balance out the potassium and the calcium. And the muscle is going to balance out the calcium and the magnesium, but it's going to be just a slight, very subtle balance. Okay. So now we're going to go into the signs and symptoms of each of potassium, sodium, calcium, and magnesium. So we're going to start off with sodium. Okay. So sodium. So what do we think of when we think of sodium? What signs?
Brain.
Brain. Okay, brain. Okay. And what is the normal for sodium, the normal levels for sodium?
135 to 145.
That's correct. 135 to 145. Okay. All right. So because we think of sodium and we think of brain, okay, what do we think in hyponatremia? Okay, so hyponatremia, let's see, why won't this thing move?
Too little sodium.
Too little sodium is in hyponatremia. Okay, so hyponatremia. Okay, so that's too little. Okay, so what kind of symptoms are you going to have in hyponatremia? If you know sodium has to do with the brain, what kind of symptoms are you going to?
Seizures.
Confusion.
Confusion. What's another one?
Dizziness.
Dizziness. Okay. Oh, that's not spelled correctly. Okay. What's another one? What's another big brain symptom?
Seizure.
Seizure.
Seizures. What was the other one? Somebody else said something? Okay, coma is going to be another one. That's going to be your most severe, okay, and hyponatremia, okay? All right, so we know, I've said it many, 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 many times, okay? What is going to happen in hypernatremia?
Thirst.
First, okay? With the above signs, correct? You're going to still have the same brain symptoms that you would have in hyponatremia, okay? Except you're going to have thirst in hypernatremia, okay? So thirst, confusion, dizziness, seizures, coma, okay? All right, so we got sodium. So this is sodium. Sodium equals brain. The normal is 135 to 145, okay? In low sodium, you're going to have all your brain issues, coma, confusion, dizziness, seizures, okay? In hypernatremia, you're going to have all of the above brain symptoms, including thirst, okay? And hypernatremia. Okay, so now we're going to move on to potassium, okay? Let's see, move this over. Okay. All right, so potassium. Okay. What do we think of when we hear potassium?
Heart.
Heart. Very good. Okay. What is the normal for potassium?
Is it 3.5 to 5?
Yep, 3.5 to 5 is the normal. Okay. Okay. Heart is a big one, okay? Heart is your big one for potassium, okay? But I also want you to think of, when you think of potassium, heart's the main one, okay? But I also want you to think of a little muscle, okay? So mostly heart, but the muscle is a little bit involved in symptoms in potassium as well, okay? So you want to think of a lot of heart, a little bit of muscle. Easy way to think of this, the heart is a muscle, okay? So that's kind of an easy way to think of both of them. So a lot of heart, a little bit of muscle, okay? Also, when I want you to think of potassium, okay, in terms of symptoms, okay? I want you to think of potassium as also doing stuff, okay? Action potential, okay? So those symptoms, those signs and symptoms that are going to show you, that are going to give you high action potential, okay, are action potential, okay, is going to be on the hyperkalemic side, okay? Those symptoms that are not doing stuff or have little action potential is going to be on the low potassium side, okay? So if you have a question on NCLEX, okay, you have a question on an exam, okay, and they don't have any cardiac symptoms in the answers, okay, that's going to be for my test, but just in case for NCLEX, for NCLEX they may not have a cardiac sign, okay? Let's say they have one of the questions is, what would be a sign and symptom of high potassium? And they have muscle weakness, diarrhea, I'm trying to think of another one. Muscle twitching and coma. Which one of those four do you think would fit for hyperkalemia after what I just said about muscle?
Weakness.
In hyperkalemia,
Would it be the twitching?
it would be the
Muscle
twitching.
twitching.
Correct. Okay. It's doing stuff. The action potential is high in hyper. Okay. Now, if it would be hypo, then the muscle weakness would come in. Okay. But hyperkalemia, you want to think muscle and you want to think high action potential. So muscle twitching would be the answer there. Okay. So just, just in case they don't have any cardiac symptoms in the problem, in the question, that's what I want you to think of when you think of potassium as well. Okay. As a second go-to. Okay. So potassium, a little heart and a little muscle, doing stuff, action potential. Okay. All right. So let's see. So in low potassium, let's see. So low potassium. Okay. You would have such symptoms as you have cardiac arrest. Okay. You'd have dysrhythmias, right? Dysrhythmias. I think that's how you spell it. Nope. It still doesn't look right. Okay. Dysrhythmias, weakness. Okay. Because you don't have that action potential when you have low potassium. Okay. It's not doing stuff. Okay. So in low potassium, you're going to have weakness. Okay. You're going to have lethargy. You're going to have decreased reflexes. And do you think you would have in low potassium? Do you think you would have constipation or diarrhea in low potassium? Which one of those GI symptoms do you think you would have? Constipation. Okay. That's correct. Okay. So everything is slowed down, okay, when you have low potassium, okay, but you'll still have the cardiac symptoms as well. You'll have the cardiac arrest, the dysrhythmias, okay. But this is, like I said, this is in case you don't see the cardiac part in the problem, okay. Always think muscle is your next go-to, okay. All right, so let's see. Oh man, why can't I do this? Okay, so I want to not make this. Hold on, guys. Let me just move this over some. Action potential and a little muscle. Okay, so high potassium. So if we talked about low potassium, we have constipation. Then in high potassium, we will have
Diarrhea.
Correct. Okay. We will have muscle cramps or twitching. Okay. Excitability in that high potassium. You have that excitability, okay, that increase doing stuff, that increase action potential, okay. Let's see if I'm getting anything else. Okay, nope, that's it, okay, and you'll still have the cardiac signs. You'll have the cardiac dysrhythmias, cardiac signs, just the symptoms, okay. So in both, you'll still have the cardiac symptoms in both low potassium and high potassium, but also think about the muscle too. Okay, the muscle and the action potential of the sign and symptom that is being offered to you in the question. Makes sense. Any questions? Okay. All right. Okay. So now we move on to calcium. Okay, so I'm going to move this over. All right. So calcium. Okay, so what do we think about calcium? When we think of calcium, what organ do we think of?
Bones.
Bones, yes. But what's another one that we talked about?
Muscle.
Muscle. And what verb did I tell y'all to think of when you think of calcium?
Lazy.
Lazy. Okay, and yes, I'm typing in all caps here because I want y'all to remember it, okay? Lazy, calcium, I want you to think lazy, okay? So what is the normal range for calcium? What did I
9.
tell y'all to remember?
9 to 11, 911.
911. You break a bone, you call 911, okay? That's the range I want y'all to remember for calcium. Break a bone, call 911, okay? Easy way, kind of fun way to remember that, okay? All right, so bringing this over. No, I don't want to do that. Okay, so here we go. All right, so if we have, okay, if we have low calcium, what signs and symptoms do you think we're going to have? If we have low calcium, are we going to be lazy?
Isn't it the opposite?
That's right. Okay, low calcium is going to be excitability. Okay, low calcium, it's the complete opposite, like Cheyenne said. Okay, low calcium, you're going to have excitability. Okay, it's not going to be lazy. Okay, it's going to be the opposite of lazy and low calcium. Okay, so we're going to have muscle cramping. We are going to have tight muscles, muscle cramping, muscle spasms. We're going to have our tetanies. Tetanies. We're going to have this over. We're going to have what's our telltale what's our signs that we're going to see in people with low calcium? What's those weird name signs?
I think I'm gonna mispronounce it, but it's Chevex and Trousseau's.
Chevestec's and Trousseau's, okay? Which one is the cheek? When you touch the cheek, the eye twitches. Which one is that? Chevestec's or Trousseau's?
Chevis.
Chevestec's. Chevestec's cheek, okay? So we're going to see positive Chevestec sign. Probably spelling this wrong. It's okay. Let's see. Let's say Chevestec. Okay, positive Chevestec sign and positive Trousseau sign. Okay. Robin, do you remember what positive Trousseau sign is?
When you take a blood pressure and your fingers do something
They twitch.
kind of weird.
That's right.
They
That's
twitch.
right. Okay.
Yeah.
Yeah, the finger and the hand twitch. Whenever you blow up the blood pressure cuff, the finger and the hand twitches. Okay, and positive Trousseau sign. Again, excitability shows that excitability, not lazy. Okay, low calcium. Okay, and also increased reflexes. Okay, because again, that's that excitability, right? Okay, so we're going to see all kinds of excited reflexes. Okay, excited muscles. Everything's going to be excited in low calcium because it's not lazy. Okay, so knowing that you know that about calcium, okay, low calcium, what do you think you would see in high calcium?
Lazy, like,
Okay, when you think of muscle laziness, what do you think of? What's a muscle lazy sign?
Weakness.
Weakness. Okay. What's another muscle lazy sign? Think stroke. What happens in a stroke to somebody sometimes?
This
I'm sorry, say again?
paresthesis.
confusion.
Yep, paresthesis. Okay. Or numbness of the extremity. Okay. Weakness, paresthesis. Let's see. So everything is slowed down in high calcium. Okay. It's the opposite of how you would think. Okay. It's the opposite of what it should be. Okay. So high calcium, everything is going to be weak. Everything is going to be lazy. Okay. Nothing's going to feel nothing. They're not, you'll have lethargy. Okay. And as far as GI sign, you're going to have constipation, lazy, not doing anything, stomach's not doing anything, stomach's lazy. Okay. So that's what I want you to think of as far as calcium. Okay. So now we're going to move on to magnesium. Okay. So let's see. So magnesium. So what did I say about magnesium? What do you remember about magnesium? What did I tell you? What does it follow? What is it similar to?
It follows calcium.
Calcium, right. Okay, so it's very similar to calcium. Okay, so you will see the similar symptoms that you would in calcium. Okay, so you are going to see in low magnesium, you're going to see that excitability. Okay, you're going to see, let's see, you're going to see the excitability, the increased reflexes. You're going to see in the muscle cramping. Okay, so you're going to see that excitability, and in high magnesium, you are going to see the laziness, okay, the weakness, the lethargy, and the paresthesis. Okay, same thing. All right. I'm sorry.
Sorry,
Say again.
I didn't mean to say that.
Okay, I was just making sure you didn't have a question. Okay, so the normal for magnesium 2 is 1.6 to 2.6.
I have a question.
Yes, ma'am.
How are we supposed to differentiate between calcium and magnesium on the exam then?
Because calcium, well, magnesium is going to, let me try to think about this. Think of a good way to tell y'all. Magnesium is going to have more contractibility than calcium. Okay. So calcium, like I said, calcium is more along the lines of bones and muscle. Okay. Whereas magnesium is more muscle and neuro. Okay. So even though it's very similar, it's going to show the similar signs. magnesium is going to be more on your excitability level than calcium. Okay, so you're going to have more nerve stuff in magnesium than you will in calcium. Good question. Does that answer your question?
Yes, it does. Thank you.
Okay. All right. Okay. All right. So does that kind of help you to kind of understand the signs and symptoms of electrolytes a little bit more? Semi. So I've seen a lot of people write this on their test when they get it. Okay. They make that grid. Okay. They make they remember where the electrolytes are balanced. Okay. Because that will also help you on the test to see, okay, they're balanced in the kidneys. So if sodium's up, potassium's down. Okay. So it'll help you to remember what's being balanced too. Okay. So a lot of people have written this down on the test. It is on Canvas too. I did do one on Canvas as well, and it has different colors and everything on it too. So I did post it on Canvas too as well. But it's a good way to like not have to not get stressed out about the signs and symptoms and have to remember every single sign and symptom of hypernatremia, hyponatremia, and so forth. Okay, you think of the organ that it's dealing with. Okay, like sodium brain, potassium heart, calcium bones. Okay, bones and muscle, and it's lazy. Calcium is lazy. And magnesium is going to be similar to calcium. It's going to be more neuro-related than calcium. Any questions? Okay. All right, so I'm going to stop sharing. All right. And I'm going to go to our PowerPoint, and we're going to now finish up with, we're going to finish up acid base today and get into pain. Okay, chapter 7. All right, so let me screen share and go to my, no, my thing's not here. Hold on, guys, 1 second. My PowerPoint up. Nope, not to be minimized. I want this to this, and this to that. Aha, here we go. Okay. Alrighty, so now we're screen sharing. Can everybody see my PowerPoint? Okay, it's not in full size yet, but okay. Okay, take a while. Okay, let's see. Let me go back. Kalimia, nope. Let's see. I'm trying to find my slide. Shoot. Hang on. Thought I had it right where I left off, but obviously I did not. Base. Okay, that's where we started with acid base. Okay, so ABGs. Okay, so I think this is where we left off. Okay, so to determine acid base balance. Okay, and I may backtrack a little bit, but just bear with me. Let's see. Go to my presentation. Okay, so I may backtrack, but these are some ABGs are going to be used to determine acid-base balance. They're going to be most of the time, they're going to be drawn by the respiratory therapist, okay, to determine the acid-base balance of the patient, okay? So in the ABG analysis, okay, so this is what's going to show in your ABGs. The PO2, the PaCO2 are carbon dioxide, the pH, the SaO2, and the HCO3, which is bicarb, okay? For problem purposes, these are the things I want you to be zoned in on? The CO2, the pH, and the HCO3. The carbon dioxide, the pH, and the bicarb, okay, for problem solving. And you will have a couple of problems on the test, a couple of ABG problems on the test that you'll have to decipher whether it's metabolic acidosis, metabolic alkalosis, respiratory acidosis, or respiratory alkalosis. Okay. All right. And we'll go over that. Okay. Next. Okay. So we're going to talk about each component of the ABG. Okay. But like I said, I just kind of want you to really focus in on the carbon dioxide, the pH, and the bicarb. Okay, so let's see. Hold on one second. Get my slides together. Okay, so PaO2 is the partial pressure exerted by oxygen in the arterial blood. Okay, so it's the pressure that oxygen brings to the table. Okay, normal value is 80 to 100. Now that is PaO2. That is not your oxygen saturation. That is something completely different. Okay, so this is not the same as your oxygen saturation. Totally different. This comes from the blood. Okay, the oxygen saturation comes from it's actually, comes, you put it on the finger to detect it. Okay, but it's more along the lines of what's in the amount of oxygen in the vascular space. We'll go over that. Okay, so PaO2 is the normal value is 80 to 100. Okay, and it indicates the amount of oxygen which is carried in the blood. Okay, PaO2. Okay, next. PaCO2 is the carbon dioxide. This is what I'm going to need you to be looking at in the problem solving. Okay, PaCO2 is the partial pressure of carbon dioxide in the arterial blood. So it's the pressure that carbon dioxide brings to the table. Okay, normal value is 35 to 45. You need to know this. Okay, 35 to 45 for CO2. Okay, know that. Okay, and it indicates, the amount of carbon dioxide in the blood. Okay, so CO2, 35 to 45. Okay, next. pH. Okay, you're also going to want to know pH in your problem solving. Okay, pH is an expression of the extent to which the blood is alkaline or acid. Okay, so it's going to tell us if our blood has too much acid in it, or if our blood has too much base in it. Okay, alkaline equals base, acid equals acid. Okay, normal value is 7.35 to 7.45. Okay, an easy way to remember carbon dioxide, CO2, take away the 7 in the pH, and you have your CO2 levels. Okay, so you know your pH is 7.35 to 4.5. When you go to write your CO2, take out the 7 and you have your CO2 level. Easy way to remember CO2. Okay. All right. Let's see. Next. SaO2 is your oxygen saturation. Okay. It's the percentage of available hemoglobin. Okay, that is saturated with oxygen. Okay, so we talked about a couple days ago, okay, your H&H, your hemoglobin and your hematocrit. Okay, your hematocrit is going to determine the amount of fluid you have in the vascular space. Okay, whereas your hemoglobin is going to determine how much blood you have in your, how much oxygenated blood you have in your vascular space. Okay, so hemoglobin equals oxygen, hematocrit equals fluid. Okay, For instance, this is the ratio of the amount of oxygen that is combined with hemoglobin to the total amount of oxygen the hemoglobin can carry. Okay, so it's the amount of oxygen, okay, whatever the pressure of oxygen that combines with that hemoglobin, okay, that combines with that hemoglobin portion of the blood, okay, to the total amount of oxygen the hemoglobin can carry. Okay, so it's that ratio. Okay, it's the ratio of the amount that combines with the hemoglobin to the total that the hemoglobin can carry, that has the ability to carry. Okay, normal value is 94 to 100. 94 to 100%. Okay, that's what you see on the screens in the patient's rooms. Okay, is your oxygen saturation. Okay, but it's not the same thing as the PaO2. Okay, PaO2 is going to be taken by a blood test only. Okay, all right, next. Let's see. HCO3, bicarb. This is another one that you're going to need to know for problem solving. Okay, this is the level of plasma bicarbonate. Okay, the amount of bicarbonate in the blood. When we say plasma, I also kind of want you to think blood too. Okay, an indicator of the metabolic acid base status. Okay, so it's going to indicate all two, just like pH does. It's also going to indicate whether or not you're too acidic, or you're not basic enough, or you're too basic. Okay, and it's also going to determine, this is also going to be you want to think metabolic when you think bicarbonate. Okay, so if the bicarbonate is high, something's going on with the metabolic system. What's another word? What did I tell you guys to think of when you think of metabolic? What organ? Do you remember?
So the kidneys?
Kidney.
Kidneys. Okay. Kidneys equals metabolic equals bicarbonate. Okay. Or think of more simple. Metabolic equals kidneys. Okay. But bicarb is going to tell you the metabolic status, whether it's too high or it's not high enough. Okay, normal value of bicarb, know this, 22 to 26. Okay, got to know that. Again, there's no cutesy way to remember it, but like CO2, you just have to remember 22 to 26 is bicarb. Okay, all right. And like I said, we're going to go through problems, and I'm going to show y'all a good way to how to solve acid base. Okay, how to solve ABGs. Base excess or deficit indicates the amount of blood buffer present. Okay, so base, or your bicarb, okay, is either in excess or it's in deficit. Okay, alkalosis is present when this value is abnormally high. So alkalosis equals too much base. Okay, acidosis is present when this value is abnormally low. So acidosis is present when you don't have enough base. Alkalosis equals too much base. Acidosis equals not enough base. Okay, all right. Respiratory acidosis. Okay, so we're going to talk about respiratory acidosis. Okay, so respiratory acidosis, okay, is going to be a pH below 7.35. Okay, because remember, below 7.35, you're going to be acidotic. Okay, so when you see this number, okay, you're going to see if it's above 7.45 or it's below 7.35, and that's going to tell you if you have acidosis or alkalosis. Okay, so in respiratory acidosis, our pH is going to be below 7.35. Okay, your PCO2, your carbon dioxide, is going to be above 45. Okay. I told you guys yesterday, always think CO2 equals respiratory. Okay. Carbon dioxide equals respiratory. Okay. So if your CO2 is greater than 45, you know you got a respiratory problem going on. Okay. And the bicarb in respiratory acidosis is going to be normal. Okay. Why? Why do you think the bicarb in respiratory acidosis would be normal? You can either chat or answer.
Miss Adams, can you repeat the question?
Yes, ma'am. Why do you think the bicarb would be normal in respiratory acidosis?
Would it be because the lungs are trying to compensate?
Not the lungs.
I mean, the kidneys would be compensating.
The kidneys are compensating. Remember phone a friend? Okay, remember the lungs and the kidneys are friends in the acid-base balance. So if one is in trouble, the other one is going to come rescue it. Okay, so when the lungs are in trouble, when you have a respiratory issue, okay, the kidneys are going to come to the rescue. Okay, and they're going to normalize everything. Okay, they're going to buffer out everything. Okay. Now, like I said before, the kidneys are slow to respond, but when they respond, they do the job. Okay. So that's why your bicarb would be normal. Okay. Because your kidneys are coming to the rescue. Okay. Okay. In respiratory acidosis. Okay. Very good, guys. Some causes of respiratory acidosis. Okay. Airway obstruction, pneumonia, asthma, chest injuries, or pulmonary edema. Okay. Anything that's going to hold on to to that CO2 and make that CO2 go up, okay, is going to cause respiratory acidosis. Okay. Chronic obstructive pulmonary disease, COPD. Okay. Emphysema. Okay. Those airways are blocked. In those conditions, the patient's not able to breathe off that CO2. That CO2 is accumulating in the lungs and it gets high and the patient goes into respiratory acidosis. Okay. So any cause that's going to keep the lungs from breathing out the CO2 is going to cause respiratory acidosis. Okay.
Okay.
Question?
Yes, ma'am. So when a patient's coding, obviously they're not breathing.
Correct.
So the respiratory acidosis, they're pushing bicarb because the kidneys aren't going to be able to compensate fast enough.
That's correct.
Okay.
Okay. Need a little boost in a code situation. Nothing's working properly in a code situation. So they will give bicarb to give the kidneys a little boost, okay, to help. Yes, very good. Good comment. Okay. Let's see. Okay. All right. So also with opiate use, which you'll learn about in pharmacology, okay, opiates are pain medications and stuff. A common side effect of opioids is that they depress the respiratory rate, okay, or they may even stop the respirations altogether, okay. So with that, okay, because you're not blowing off CO2, okay, and you're not breathing like you should, that CO2 is going to be retained. It's going to build up, and you're going to have respiratory acidosis. You're going to have too much CO2. Okay. All right. Let's see. Next. Okay. Some signs and symptoms. Okay. Difficulty breathing. Okay. Most of your signs and symptoms are going to be respiratory related when you're in respiratory acidosis. Okay. You're going to have a history of respiratory obstruction, acute or chronic. Okay. Dyspnea, okay, not able to breathe, okay, shortness of breath, can't breathe, okay, weakness, dizziness, restless, sleepiness, or change in mental alertness, okay. All of these, even though they're more brain symptoms, okay, these are all they're also slow symptoms. They're also lazy symptoms, okay? So when the patient has lazy symptoms, they're not gonna be breathing real good, okay? That laziness is gonna take over the lungs, okay? And the lungs are not gonna be able to breathe off the CO2. They'll retain the CO2. Too much CO2 equals respiratory acidosis. Okay. Okay. Let's see what time it is now. Okay, next. Management. So how are we going to manage? What are we going to do for respiratory acidosis? Okay, Cheyenne said it. She said you're going to give bicarb. Okay, you're going to get those kidneys, phoning a friend. Okay, you're going to get those kidneys on board. You're going to try to get those kidneys to the rescue, but you're going to get a little jump on it by giving them that extra bicarb so that bicarb can get on board and start evening things out. Okay, because you got too much CO2 on board in respiratory acidosis. Okay, so you're also going to establish and you're going to maintain an airway. Okay, because if something's stuck in the airway, in the patient's airway, okay, and they're not able to breathe properly and they're not able to breathe off that CO2, okay, those CO2, that CO2 is going to get retained in the lungs, build up, too much CO2 equals respiratory acidosis. Okay, so they're going to want to put in an airway to avoid that obstruction so that patient can start breathing off that CO2. Okay, they may need to give the patient a tracheostomy, or they may need to put an endotracheal tube or an ET tube in the patient, okay, and put them on a ventilator. Okay, oxygen administration, okay, is also going to be a way to get that patient to start breathing better, opening up those lungs, opening up that chest so that patient can breathe better and expel those CO2 ions, okay, or that CO2 in general, okay, and mechanical ventilator we talked about, okay. We may need the machine to breathe for the person to be able to get those CO2 ions out. Okay, any questions there? Okay, always think respiratory acidosis, too much carbon dioxide in the lungs. Okay, so it's going to be a breathing issue, okay, with these patients. All right, and the way we want to take care of that is by doing breathing things that are going to be helping them to breathe out the CO2. Okay, any questions? Okay, all right. Conservative treatment. Okay, so these are kind of some more not so aggressive techniques such as, mechanical ventilation, stuff like that. So these are some things that you can do for the patient. If your patient's just kind of teeter-tottering on that respiratory acidosis, but they're not yet into full-blown respiratory acidosis, but they're almost there, these are things that you can do to help them to breathe out that CO2 and to breathe better, okay? Postural drainage, okay? You either lay them on their side, okay, or sit them up nice and tall in a high Fowler's position so that the chest is open, okay, so that the airways are open so the patient is able to breathe better, okay? Deep breathing exercises, okay? Bronchodilators and antibiotics if indicated. Okay, bronchodilators are going to open up those airways. They're going to open up the airways so that the patient can breathe out the CO2 better. Okay. Use caution with narcotics, hypnotics, and tranquilizers. Okay, because these are going to depress the respiratory system. We don't want the respiratory system to be depressed and respiratory acidosis. We want that respiratory system to be up and running. Okay, we want those CO2 ions, we want that carbon dioxide out. Okay, and we need those breathing muscles. We need that respiration, those respirations and breathing muscles to be on their game to be able to expel that CO2. Okay. Okay, next. All right, so that is respiratory acidosis. Any questions with respiratory acidosis? Too much CO2, respiratory problem, we need to get rid of it. We need to do things to the body to get rid of it, okay? We need to help the body to breathe better to get rid of the CO2 in respiratory acidosis, okay? Okay, let's take a little break. We're gonna take about a 5-minute break, come back, and we'll start with metabolic acidosis. Okay, guys, we're gonna go ahead and get started back. So everybody come back on. I am recording. I have a sticky note that tells me to record, to remind me to record, but just in case, if you guys don't see it recorded, let me know, okay? Okay, so I'm gonna go back to our PowerPoint. Okay, so now we're going to talk about metabolic acidosis. Okay, so metabolic acidosis, metabolic acidosis, okay, is going to be, okay, when you have too much acid still, okay, or more along the lines of I guess I said that wrong. Scratch what I just said. You don't have enough base, okay? In metabolic acidosis, you're lacking base, okay? And you may have a little bit too much acid, but your problem, because it's metabolic, okay? And we think metabolic equals kidneys equals base, okay? You don't have enough base, okay, in metabolic acidosis, okay? So metabolic acidosis, your pH is going to be 7.3, is going to be less than 7.35. So you're going to be on the acidic side. Okay, so you're going to say acidosis because your pH is less than 7.35. Your PCO2 is normal because your lungs are kicking in to help. Okay, because it's a metabolic problem. The kidneys are in trouble. Okay, so the lungs are now going to come and help them. Okay, the lungs are going to come and help. So your PCO2, your CO2 is going to be normal in metabolic acidosis. Okay, because your lungs are coming to help, and it's going to buffer out everything. Okay, your bicarb is going to be low. Your base, bicarb, base or bicarb, base and bicarb are going to be the same thing, okay? Your base is going to be too low, okay? So that's what's going to tell you that it's metabolic acidosis, okay? So pH less than 7.35. CO2 is going to be normal. HCO3, bicarb, base is going to be less than 22. Because our base range is 22 to 26. Okay. Okay. All right. Next. Let's see. Okay. Causes. Okay. Some causes of metabolic acidosis. Okay. Is going to be excessive loss of bicarb ions from diarrhea. Okay. Bicarb equals base, okay? So when you're having diarrhea, okay, you lose a lot of bicarb in diarrhea, okay? So you lose a lot of bicarb, you don't have the bicarb, you go into metabolic acidosis, okay? Renal failure is another cause, Okay. The kidneys buffer the system by using bicarb. If the kidneys don't work, you don't have that bicarb buffer, so you don't have any bicarb, so you're going to be in metabolic acidosis. Okay, no bicarb, no to little bicarb because of kidney failure will be metabolic acidosis. Okay, diabetic ketoacidosis is another cause. Okay, when a patient is goes into diabetic ketoacidosis. Okay, the diabetes makes them acidotic. Okay, so the diabetes makes them produce an overabundance of CO2, but it tells them not to produce bicarb when they're in diabetic ketoacidosis. So they're not going to have enough bicarb. They'll be in metabolic acidosis. Okay. Hyperkalemia. Okay. High potassium. Okay. High potassium is going to cause metabolic ketoacidosis. Okay. I mean, metabolic acidosis. Sorry. Okay. For the same way renal failure does. Okay. Hyperkalemia is going to do a number on the kidneys. Okay, it's going to screw up the kidney function. The kidneys are not going to be able to produce the bicarb. Therefore, they're not going to have any bicarb, metabolic acidosis. Okay, all right. So hyperkalemia does it because it's pretty much does the same thing as renal failure. It's going to do a number on the kidneys. Okay, it's going to damage the kidneys and mess up the kidneys. The kidneys are not going to be able to produce the bicarb. Okay, metabolic acidosis. Okay, next, signs and symptoms: weakness, lethargy, headache, confusion. These symptoms progress to stupor, unconsciousness, coma, and death. Okay, so those are going to be some signs and symptoms of metabolic acidosis. Okay, weakness, lethargy, headache, confusion. Okay, I really kind of want you to be more concerned, not so much concerns with signs and symptoms of these conditions. Okay, just kind of know if it's respiratory, they're going to have breathing problems. If they don't have any kind of breathing problems, it's going to be more on the metabolic side. Okay, the signs and symptoms. Okay, that's how I want you to kind of remember signs and symptoms. So don't get too bogged down. So as you can see, this is a metabolic problem, metabolic acidosis. So you don't see a whole lot of respiratory issues here. Okay, you're going to see weakness, lethargy, headache, confusion. These are more brain symptoms, not necessarily respiratory symptoms, because you're in metabolic acidosis. Okay, any questions there? Okay, next, ketoacidosis. Okay, so ketoacidosis, okay, is a form of metabolic acidosis. Okay, you can get ketoacidosis from vomiting and diarrhea. Okay, from getting rid of all those bicarb in your body through vomiting and diarrhea. Okay, so in ketoacidosis, this is extremely important. Okay, you are going to have this I know I just said you don't have a whole lot of respiratory symptoms in metabolic acidosis, but in ketoacidosis, you are going to have deep, rapid breathing or Kussmaul's respirations. Why are you going to have that? Because your lungs are coming on board. Okay, the lungs are coming to help, and they're going to tell the body, okay, we need to help out the kidneys. The kidneys are in trouble. So start breathing heavy. Okay, start breathing fast. Okay, because the kidneys are in trouble. There's not enough base. There's too much. There's not enough base. We need to get some acid. We need to get some acid on there. Okay, so I'm sorry, there's not enough base, right? Not enough bicarb. So the lungs need to kick in and start putting in some CO2. Okay, deep, rapid breathing, Kussmaul's respirations. That is a compensating mechanism that the lungs do in ketoacidosis. Deep, rapid breathing. Know that. Very, 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 very important. Okay. And in ketoacidosis, they may secrete urine with a low pH. Okay. So the urine is going to be acidotic. Okay. Because there's no base. Okay. There's no base there. There's no to little base. Okay. And the low pH is also going to be acidotic because of the lungs kicking in. Okay, the lungs coming in this Kussmaul's respirations and bringing in all this CO2 into the body, okay, to be able to buffer out, to be able to buffer the system with the low bicarb, okay. So you may have a lower acidic pH because of the breathing and ketoacidosis. Okay. All right. Next. Treatment. Okay. You're going to treat the underlying cause. What does that mean? So whatever is causing the metabolic acidosis, okay, the metabolic acidosis, whatever is causing the patient to not be able to make bicarb ions, you're going to treat that. Okay, whether it be the renal failure, whether it be the diarrhea and vomiting, okay, that's causing the patient to lose all that bicarb, you're going to treat those causes first. Okay, and if you just, it's as simple as just treating those causes. Okay, if you don't have those causes, then you won't have the bicarb loss. Okay. Treatment in diabetic ketoacidosis is to give insulin. Okay, so you're going to give insulin in diabetic ketoacidosis. The blood sugar is going to be extremely high. Okay, so you're going to give that insulin, okay, to balance out that blood sugar. Okay, and to also, insulin also binds with bicarb too, as well. So it does have a effect on bicarb production as well. Okay, so you want more bicarb here because in respiratory acidosis, no, in metabolic acidosis, sorry, you don't have enough bicarb, so you need bicarb. So insulin does help in the production of bicarb. Okay, dialysis. Okay. Dialysis is another treatment for metabolic acidosis. Okay. Dialysis contains bicarbonate in there, in the stuff that cleans the blood. Okay. So when a patient goes on dialysis to clean their blood, okay, the stuff that the dialysis machine uses to clean the blood has bicarb in it already, okay? And the doctor can make an order to add bicarb to the solution that's cleaning the blood, okay? So you give dialysis, you give bicarb, you try to fix that metabolic acidosis because in metabolic acidosis, they don't have enough bicarb, okay? And of course, like Cheyenne said, you would give IV bicarb or lactate. Okay. Lactate does the same thing. It helps produce the bicarb too. Same thing as insulin. Does the same, very similar thing that insulin does. Okay. So you would just give them straight IV bicarb. Okay. When they're in metabolic acidosis to get some bicarb on board because the patient doesn't have enough bicarb. Any questions? So metabolic acidosis, I want you to think along the lines of the patient doesn't have enough bicarb. We need bicarb on board. Okay. We need bicarb on board. Not enough bicarb. Any questions? Nope. Okay. Okay. Moving right along. Okay. So now we're going to move into respiratory alkalosis. Okay. So what does respiratory alkalosis tell us? There's a problem with the lungs. Okay. Because it's respiratory. So we got a breathing problem here. Okay. And alkalosis means we have too much bicarb. Okay, we have a bicarb problem. We have too much bicarb here. Okay, so in respiratory alkalosis, okay, your pH is going to be above 7.45. Okay, because you're on the alkalotic side, you're on the base side. Okay, in respiratory alkalosis, your PaCO2, your bicarb is going to be below 35. Okay. So so here in this situation, okay, you may have too much base, but more along the lines of you don't have enough CO2. Okay, so in respiratory alkalosis, main thing to think about, not enough CO2. Okay, lungs are not producing enough CO2. Okay. All right, so CO2 is going to be low. It's going to be below 35. And the bicarb is going to be normal here. Okay, I know that I just said that they have too much base on board, but initially the bicarb may be normal because the kidneys are coming to help out the lungs in respiratory alkalosis. Okay, so this is a more of a not enough acid. Not enough CO2, not enough carbon dioxide here in respiratory alkalosis. Okay. Not enough CO2. CO2 is low. Okay. All right. So some causes, okay, is going to be hyperventilation, a rapid respiratory rate resulting in respiratory alkalosis. Okay. So here, okay, you're getting rid of that CO2 too fast. Okay, the CO2 is leaving the body too fast. So hyperventilation is going to be a cause of respiratory alkalosis. Okay, because you breathe in, okay, the body's not having time to retain that CO2. Okay, and the CO2 is just getting breathed out. Okay, and the body's not able to retain it. Low CO2, respiratory alkalosis. Okay, it is usually caused by anxiety, high fever, and an overdose of aspirin. Okay, not 100% sure what aspirin has to do. I'll have to look that up. Okay, with that, but I know when you're anxious, okay, as somebody that has anxiety, okay, you breathe super, super quick. Okay, you have a very, very high, okay, so you do tend to hyperventilate when you're anxious, okay, and that will cause that excess release of carbon dioxide. Body doesn't have time to retain it. Low CO2, respiratory alkalosis, okay. Hyperventilation can be caused by hypoxemia, reactions to certain drugs, pain, and panic. Okay, so you may start off with these symptoms, drugs, pain, and panic, and then go into hyperventilation, then go into respiratory alkalosis. Okay, overzealous use of mechanical ventilation can also cause hyperventilation. Okay, so before we said we wanted to put these people on ventilation to be able to retain CO2 in the patients in respiratory acidosis. Talk about that respiratory acidosis. Okay, we wanted them to breathe off the CO2. In respiratory acidosis, going back, okay, backtracking, we wanted these people to get rid of CO2. Okay, so we put them on a ventilator to get rid of the CO2. Well, now the ventilator may be working a little bit too well because now the patient's in respiratory alkalosis. They're breathing the CO2 off too fast. Okay, body's not able to retain it. Okay, low CO2, respiratory alkalosis. Okay, head injuries, okay, may also lead to hyperventilation. Okay, so somebody that has a head injury, okay, it has to do with the brain stem and how it's connected to the lungs, okay? But somebody that has a head injury can also hyperventilate, okay? They can hypoventilate too, okay, when they have a head injury, but they can hyperventilate. If they hyperventilate, okay, they're getting rid of the CO2 too much. Body's not able to retain the CO2, low CO2, respiratory alkalosis, okay? All right. Any questions so far? Okay. Signs and symptoms. Hyperventilation, deep, rapid breathing. Okay. What do you do when you hyperventilate? You deep. Okay. You breathe fast. Okay. Tingling of the fingers, pallor around the mouth, dizziness, and spasms of the muscles and hands. Okay. But in respiratory alkalosis, you'll mostly have the respiratory signs, but these are some other non-neuro signs, non-respiratory signs that you will see, okay, in respiratory alkalosis. Okay. All right. Pallor around the mouth. Does anybody know what pallor is?
Pale.
Pale. Okay. Pale equals low blood, right? Okay. So that would make sense, right? Because that patient is blowing off CO2 too fast. They're not retaining it. So they're not getting the proper oxygen CO2 balance in their blood. Okay. So they're going to lose blood to that particular area and it's going to be pale. Okay. So that's a little way to kind of think about it. I know it's a little bit much. Okay. But blood's not going to be oxygenated in respiratory alkalosis. Okay. Because you don't have enough CO2 to balance out that oxygen content. And you need both oxygen and CO2 for blood to be able to be properly oxygenated. Okay. All right, so those are just some signs and symptoms of respiratory alkalosis, but I really want you to focus on deep, rapid breathing in respiratory alkalosis, hyperventilation. Okay. Next, treatment, address the underlying disorder. Okay, take care of what's making that patient breathe heavy. Is it anxiety? Is it drugs? Okay, we may need to reverse the drug that's making them hyperventilate. Okay, we may need to give them a sedative to calm them down from hyperventilating. Okay, so we need more CO2. Okay, what's a common thing that when somebody's hyperventilating, what do you get them to do? What do you see a lot of?
Breathing.
Breathe in a paper bag. Okay, because you want that CO2 to go back into the lungs. Okay, you don't want it to go out into the atmosphere, into the environment. So if you get them to breathe in a paper bag, they're breathing in that CO2 just like they're expelling it, but that CO2 is staying in that paper bag, and when they're breathing it in, it's going back into the lungs. Okay, so that's why you tell somebody to breathe into a paper bag when they're hyperventilating, because they need CO2. Okay. Prevent further hyperventilation and help the patient reestablish a normal level of carbon dioxide in the blood. Okay, so we're going to do everything we can to keep that patient from hyperventilating, to stop that hyperventilation. Okay, sedatives may be needed to given to calm the patient. Okay, so we may need to give these patients sedatives. Okay, however, we have to be careful because we don't want to over sedate them, because then we may put them in respiratory acidosis. Okay, because then if we over sedate them, then they're not breathing, then they're retaining too much CO2. Okay, and then we got another problem on our hands. So we need to be careful about sedating those particular patients. Okay, but if the hyperventilation is severe enough, okay, then we need to get the breathing down, and we may need to give them the sedatives, okay, to help them to stop hyperventilating so they can retain CO2. Retain CO2, CO2 gets in the lungs, you reverse the respiratory alkalosis. Okay, all right, let's see. Next, okay, some more treatment for respiratory alkalosis. Okay, you want to aid in the retention of carbon dioxide. So you want to get those people to hold on to that CO2. Okay, the patient may be instructed to hold the breath or to breathe in a paper sac. We just talked about that. Okay. This recycling of carbon dioxide can eventually restore normal carbonic acid levels in the blood, or get the patient to retain that CO2, get those CO2 levels up in the blood, and reverse that respiratory alkalosis. Okay. All right. Okay. Breathing in a paper bag. Huge. Okay. Big deal. Big deal in respiratory alkalosis. Okay. Tell them to breathe in a paper bag. Okay. All right. Let's see. So any questions on respiratory alkalosis? Guys, if you can put your cameras on, I need you guys to put your cameras on, okay? If you're able to do so, okay? All right, so now we're moving on to metabolic alkalosis, okay? So metabolic alkalosis, okay, is going to be a problem with the kidneys, okay? The kidneys are in trouble, okay? And you're going to be having too much bicarb, okay? Kidneys are in trouble. You have too much bicarb, okay, for some reason, okay? Your pH is going to be above 7.45, okay? If your pH is above 7.45, that's going to make you alkalotic, okay? That's going to make you basic, okay? More basic. PaCO2, that's your carbon dioxide, is going to be normal because your lungs are coming to the rescue. Okay, in metabolic acidosis, your kidneys are in trouble, your lungs are coming to the rescue. Okay, your bicarb is going to be high. It's going to be above 26. You're going to have too much base, too much bicarb on board in metabolic alkalosis. Okay, all right. Next, some causes, okay, are going to be vomiting. Okay, now I know I said before, you lose, sometimes you lose bicarbonate when you vomit, okay? You can also, depending on the, let me see how I can say this, depending on the functioning of your kidneys can sometimes overfunction and vomiting, okay? And they can produce more bicarbonate when you vomit, okay? So vomiting can also sometimes cause alkalosis, metabolic alkalosis, okay? It can cause metabolic acidosis, but it also can cause metabolic alkalosis. So the deciphering factor between whether or not it's acidosis, okay, is going to be your bicarb, okay, whether your bicarb is low or whether your bicarb is high, okay? If your bicarb is high when you have vomiting, then you're going to have metabolic alkalosis. If your bicarb is low when you have vomiting, then you're going to have metabolic acidosis, okay? So it's going to depend on what your body's doing with your bicarb, whether it's holding on to it or whether it's getting rid of it, okay? Extensive gastrointestinal suctioning, Okay, same thing. Okay, depending on, we talked about here would be more along the lines of the kidneys, but here would be more along the lines of the GI tract and the absorption of the bicarb ions in the GI tract. Okay, your GI tract may do a too good of a job of absorbing the bicarb ions, okay, and gastric GI suction. When a patient's being suctioned for a GI reason, okay, the intestinal tract may overproduce bicarb, okay. When that happens, it can put the patient into a metabolic alkalosis state, okay. Now, if the GI tract does the opposite, okay, and doesn't produce the bicarb, okay, then you'll have that bicarb, what bicarb you do have, you'll have it sucked out and you'll be in metabolic acidosis. So it depends here, again, on your bicarb, what your bicarb is showing you in gastro GI suction. Is your bicarb low or is your bicarb high? That will tell you whether it's acidosis or alkalosis, okay? Hypokalemia, so low potassium, okay? So we said high potassium caused metabolic acidosis. Hypokalemia is going to do the opposite. It's going to cause metabolic alkalosis, okay? For the same reason, okay? Because bicarb and potassium go hand in hand. Okay, so if you have, well, no, they go opposite. So if you have low potassium, you're going to have high bicarb. Okay, and if you have, it's going to be the opposite. If you have high potassium, then you're going to have low bicarb. Okay, high potassium, low bicarb, low potassium, high bicarb. Okay, excessive consumption of antacids with bicarbonate. Okay, so we're talking about metabolic alkalosis. We're talking about too much bicarb. Okay, so remember I said a lot of antacids have a lot of bicarb in them. Okay, so if you have a patient that is chewing antacids like crazy, okay, like candy, okay, they can become metabolic alkalotic because they have too much bicarb on board because of the antacids with the bicarb. Okay, any questions? Okay. Let's see, I gotta chat. I am trying, but my settings are off. Okay, all right. All right, so some signs and symptoms of this is metabolic alkalosis. Okay, so kidneys are in trouble, too much base, and metabolic alkalosis. Okay, so neurologic signs are going to be irritability, disorientation, lethargy, muscle twitching, tingling and numbness of the fingers, and convulsions. Respiratory manifestations, okay, because the respiratories are coming in to help. Okay, slow, shallow respirations, decreased chest movements, and cyanosis, and metabolic alkalosis. Okay, so it's gonna, if you have too much base, okay, from the respiratory standpoint, the respiratory wants to get more carbon dioxide in the body because the base is too high. Okay, so the respiratory system is going to say, okay, respiratory system, the kidneys are in trouble, so I need you to hold on to those CO2 ions. I need you to hold on to that carbon dioxide because the kidneys are in trouble and they got too much base down there. So we need to hold on to the CO2. Okay, so it's going to tell the body, slow your respirations, shallow respirations, hold on to that CO2. Okay, so those are going to be some respiratory manifestations of metabolic alkalosis. Okay, trying to get the body to hold on to those CO2 ions, those carbon dioxide ions, okay? And there may be symptoms of potassium and calcium depletion, okay, when you have metabolic alkalosis, because like I said, too much base, not enough potassium. Bicarb and potassium work opposite, okay? So not enough potassium, okay? Not enough bicarb. Same thing with calcium, okay? Same thing. All right, so symptoms of potassium and calcium may be depleted, okay? Next, if the alkalosis progresses, tetany, seizures, and coma, okay, will come about. Okay, this is in metabolic alkalosis, base is too high, kidneys are in trouble, okay? So if the alkalosis doesn't get corrected, okay, if that base keeps getting higher and higher and higher and higher, okay, you'll get tetany, seizures, and coma, okay? Tetany is characterized by severe muscle cramps, carpopedal spasms, laryngeal spasms, and stridor, shrill, harsh sound upon inspiration. Okay, so this is a little bit more of a respiratory symptom, even though it's more metabolic. Okay, you're dealing with a kidney problem, you may have this small respiratory problem of stridor. Okay, and that is more along the lines of not really a respiratory problem, but more of a respiratory muscle problem. Okay, the muscles are severe, the respiratory muscles are severely excited. Okay, when you have too much base on board. Okay, so the respiratory muscles are going to spaz out. Okay, and when the respiratory muscles spaz out, it causes this stridor here. Okay, shrill, harsh sound upon inspiration. Okay, but for the most part, in metabolic alkalosis, you're going to have those hyperactive brain symptoms. Okay, you're going to have the tetany, the seizures, the coma, the muscle cramps, the laryngeal spasms. Okay, you're going to have those major hyperexcited brain symptoms in metabolic alkalosis, too much base. Okay, any questions? Okay. Treatment. Okay, treatment for metabolic alkalosis. Okay, so we're gonna correct the underlying cause. Okay, that's what you're gonna do most of the time in these acid-base imbalances. You're gonna correct what is actually causing the acid-base imbalance. If it's a respiratory issue, we're gonna correct the respiratory issue. If it's a muscle issue, okay, if it's an overexcitability of the muscles because of low potassium or high potassium, okay, we may have to give them or restrict their potassium. Okay, you want to correct the underlying cause. You correct the underlying cause, you'll correct the acid-base imbalance. Okay, you want to restore the body fluids to a less alkaline state. Okay, so in that case, you may have to, with this, okay, restore the body fluids to a less alkaline state. So you want to may give a little bit more acidity to your IV fluids, okay, to get them to a less alkaline state, okay, and that acidity kind of goes along a little bit with the stuff, the osmolality. So if you add a little bit more stuff to your IV fluids, okay, you're going to add a little bit more of an acidic factor, okay, to your IV fluids and your body fluids, which is going to make the blood less alkaline, less basic, okay? So you may need to add a little bit more stuff to your IV fluids to make them more acidic, okay? Fluid and electrolyte replacement orally and parentally as needed. Parentally means IV, okay? IV or IM, okay? So most of the time it's going to be IV, okay? Emergency measures, including the administration of an acidifying solution, such as ammonium chloride. Okay, so ammonium chloride is an acidifying solution. It has a lot of acid in it. So if a patient is super basic, okay, in metabolic alkalosis, okay, then you want to get them to a little bit more acidic. So you may have to give them an acidifying solution to make them a little bit more acidic, balance it out, get a little bit more acid on board here, because there's not enough acid on board. There's too much base here. Okay. All right. Let's see next. All right. So acid balance imbalances, home care considerations. Okay. So this is when you may be the home health nurse. Okay. You may have a patient that had a history of this, had a history of either respiratory acidosis, alkalosis, metabolic acidosis, or metabolic alkalosis. Okay. These are some things that you're going to tell them as the home care patient, okay, to be mindful of. Okay. Fluid intake and restriction. Okay. These things have a lot to do. Okay. They can be that underlying cause that can be corrected, that can correct the acid base imbalance. Fluid intake and restriction, sodium restriction, okay, manage that underlying cause. So whether it be diabetes, okay, diabetes was a huge one that we saw, okay, that caused respiratory acidosis, metabolic acidosis, okay, so you want to keep that diabetes under control. You want to tell the patient to take their blood sugar, okay, I mean, to take their insulin when they need to. Don't let their blood sugar get high, okay, and make sure they get lab monitoring their test, you know, that sort of thing, blood work, to make sure those things, you know, those ABGs, those lung function tests, if it's a respiratory issue, okay, you want to make sure they're getting those tests and those tests are staying within normal limits. If it's a metabolic issue, metabolic equals kidneys, okay, you want to make sure they're going to their dialysis like they should, okay, you want to make sure their kidney labs are okay, okay, you want to make sure their potassium, their sodium, all those things are good, okay, because if those things get out of whack, okay, then they're going to cause the acid base imbalance. Okay. Any questions? I know this is a lot. Okay. Like I said, I have a couple videos on a couple YouTube videos on this, okay, on Canvas, that may be beneficial for some of you to watch, because it may give a little bit more insight, okay, on how to decipher signs and symptoms, okay, of acid-base imbalance, okay. But now, let's see, what time is it? 9:46. Okay, now we're going to do some problems, some acid-base problems, and it's going to make it a little bit more, I'm going to kind of teach you how to set it up so you can not get so confused, okay? So, let me stop sharing. Okay. Now, let you go. Let's see here. Okay, okay. Little. Okay. All right. So I'm gonna say, okay, I'm gonna go to my whiteboard. Okay, and I'm gonna clear. I want to clear. Not clear. Save PDF. So clear all drawings. Okay. All right. I'll move this over here, and I want to do this. All right, okay. So. So here's the first problem that we're going to do. Okay, so our pH, we have a pH of 7.23. Okay. We have a CO2 of 37. And we have a bicarb, 18. Okay. So I'm going to show you how to set this up. Why won't it let me increase this box? All right. 18, not 1, not 18. Okay. All right. So the first thing you're going to do, okay, first thing you're going to do here, you're going to look at your pH. Okay. Well, no, before you even do that, when you get your test, this is what you're going to do. Okay. You're going to come over here. Okay. And you're going to write down your normals. pH 7.35 to 7.45. Your CO2, like I said, you're going to get rid of the 7 and you're going to bring down the 35 and 45. And that is going to give you your range for CO2. Okay. Your bicarb, like I said, no fancy way of knowing this. It's just one of those things you got to memorize. One of the few things that you're going to have to memorize in nursing. Okay. 22 to 26. Okay. Is going to be your bicarb. Okay. So you're going to write down those normals when you get your test. Okay. All right. This is going to help you a lot. Okay. So I'm going to go back over here to this little doohickey here. Okay. Sorry, guys. Okay. I'm trying to do this. Keep it all in the same area. Okay. So in this problem, okay, your pH is 7.23. Is that below or above 7.45? Is that below 7.35 or above 7.45?
Below 7.35.
Below. Okay, correct. Okay. So it's going to be below. So is it going to be acidosis or alkalosis?
Acidosis.
Acidosis. Okay. So we have that. Okay. So that's the first thing you're going to look at, your pH, to determine whether or not it's acidosis or alkalosis. Okay. Then you're going to look at your CO2. Okay. Is your CO2 normal or is it abnormal?
Normal.
Normal. Okay. CO2 is normal. Okay. So we know it's not respiratory. Okay. Because the CO2 is normal. Okay. However, I'm going to teach you another little trick to understand this. Your bicarb here is low. Okay. So the bicarb is low. All right. So bicarb. Oh my God, why won't it let me do this? Okay, so bicarb is low. Okay, so bicarb is low. Okay, so this is going to be your abnormal. Okay, your bicarb is low. This is your abnormal. So then you're going to say, what direction is my abnormal lab going in relationship to my pH? Okay, so here I see, and this is going to make sense, I promise. Okay, this is saying that the bicarb, the pH is low. Okay, so I'm going to come over here. Okay, I'm going to come over here and I'm going to type in. Why can't I type in it? I want to type in an arrow. Okay, so I'm going to type in an arrow. I'm going to draw an arrow. Okay, so the pH here is low. It's going down. Okay, so my HCO3, my bicarb is my abnormal lab. Okay, so this is low. My bicarb is low. Okay, so then, okay, I want you then to think of the word Rome to determine whether or not it's metabolic or respiratory. Okay. Okay, so I want you to think of Rome. Okay. So Rome is going to be respiratory, opposite I'm learning, and metabolic hold on, is going to be equal or same. Okay, I want you to think of equals the same direction. Okay, so because your pH, okay, so we already know it's acidosis, okay, because our pH is low. Acidosis. Better than using the text, okay? So we're going to look at what direction our pH and our abnormal lab is going. In this case, it's our bicarb. So it's going in the same or equal direction. So what is that going to be, metabolic or respiratory?
Metabolic.
Metabolic, okay. And I believe I said respiratory before. No, I didn't say respiratory. I said metabolic, but this is another reason, this is another way, an easy way to do a problem, okay? Using the Rome method, respiratory opposite, metabolic equal or same, okay? So to determine, you're gonna be looking at your, let's see, you're gonna be looking at your pH and your abnormal lab. Whichever abnormal lab it is, you're going to be looking at that in relation to your pH and what direction is it going in relation to your pH. So because this is going in the same direction, it's going in the equal or same direction, it's going to be metabolic. Any questions? Make sense? Clear as mud? Okay, let's do another one. Okay, so let's clear this. Let's clear this one. Okay, so here's my problem. pH of 7.5. Okay. CO2 32. HCO3 HCO3 of 24. Okay. All right. So come back over here. We write all of our stuff down. Okay. We write pH. We write our normals 7.35 to 7.45. CO2. Take away the 7. 35 to 45. Bicarb, HCO3, no fancy way, 22 to 26. Okay. And then we're going to write our Rome. Okay. Okay. Respiratory, opposite. I'm going to abbreviate for time's sake. Metabolic, equal, or same. Okay, all right. Sorry about my handwriting here. Okay, so let's start with our pH first. Okay, our pH is what? Is it high or low?
High.
It's high.
Hi.
High. Okay, so we're going to write our 2 blanks down here. So if we know it's high, okay, are we going to be acidotic or alkalotic?
Alkalotic.
Alkaline.
Alkalotic. Okay, we're going to be alkalotic because we're high. Our pH is high. It's above 7.45. It's above 7.45. It's 7.50. So it's going to be alkalosis. Okay, so we know that. We got that. So now we need to determine whether or not it's respiratory or metabolic. Okay, so is our CO2 normal?
No.
No, our
No.
CO2 is low. Okay, so we're going to put a little arrow here that it's low. Is our bicarb normal?
Yes.
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 Bicarb is normal. Okay, so I'm going to put a line that's going to tell me that it's normal. Okay, all right, so we have our CO2, which is abnormal, and our pH, which is abnormal. We're going to look at those two and see what direction they're going in. What direction are they going in?
Opposite.
Opposite.
Opposite, which means it's going to be what?
Respiratory.
Respiratory. Okay, respiratory. Respiratory opposite. Okay. So that's how you determine, that's how you get your respiratory alkalosis. So your first step, you're going to determine whether or not it's acidosis or alkalosis based on your pH. Second step, you're going to see which one is your abnormal, which one out of your CO2 or your HCO3 is going to be abnormal, and you're going to compare it to your pH and see which direction it's going in. If it's going in the opposite direction, it's going to be respiratory. If it's going in the equal or the same direction, it's going to be it's going to be metabolic. Okay. Any questions on how to solve ABG problems?
Miss Adams.
Yes, ma'am.
I don't have a question about that, but I have a question. Are these the way your question's gonna be set up on the test?
Yes, ma'am.
Okay.
The problems for
Yes, ma'am.
acid base, this is how I'm going to put these, this is going to be the problem. Okay. And I'll tell you, I'll put it in multiple choice. I'll say, is this respiratory alkalosis? Is this metabolic acidosis? And so forth. And you'll have to choose which one it is. Answer your question? Did I answer your question?
Yes, ma'am. Yes, ma'am. Thank you.
Mm-hmm. Okay. All right, let's take a little break. Let's take about a 5-minute break. We'll come back and we will start on pain. Okay, chapter 7 and the care of the patients with pain. Okay, guys, we're gonna hop on. I'm still recording, so I'm good. Okay. Let's see. Give me a second here. To go back to Canvas. Let me get my PowerPoint up. I need. Okie dokie. Share my screen. PowerPoint. All right. So now we're going to be talking. We're in chapter 7 if you're following along in your book. Okay. We're going to be talking about now how to take care of your patients with pain. Okay, that have pain. All right. We talked about the basic fluid and electrolytes, acid base. Okay, so that's kind of the precursor to med-surg care. Okay, so this will be your first med-surg system, I guess, that you'll be learning about. And it's a pretty important one because a good percentage, probably 80 to 90%, 80 to 99.9% of the patients that you're going to be taking care of in the hospital are going to be having some type of pain, okay? Because they wouldn't be in the hospital if something wasn't wrong, okay? So a good percentage of the time you will have your patients having pain issues. So that is why you have to learn how to take care of those particular patients, okay? So some theory objectives here. Okay, we're going to review the gate control theory of pain and its relationship to nursing care. Okay, so why do we care about the gate control theory? Okay, because it's going to help us to decide what our care is going to be for these patients. Okay, we're going to demonstrate an understanding of the current view of pain as a specific entity requiring appropriate intervention. Okay. Compare nociceptive pain and neuropathic pain and the nursing care for each. Okay. And we'll go over all these in greater detail. Okay. Explain how pain perception is affected by personal situations and cultural backgrounds. Okay. Culture affects pain. It affects how people perceive pain. Okay. How a patient grew up affects pain and pain perception. Okay. Analyze the major differences between acute and chronic pain and their nursing management. So how we're going to manage acute pain is going to be slightly different than how we're going to manage chronic pain. Okay. We're going to demonstrate the use of the nursing process, assessment, diagnosis, planning, implementation, and evaluation when caring for patients experiencing pain. Okay. Give examples of the different pharmacologic approaches to pain. Okay. Pharmacologic means medicine. Okay. Dealing with medicine. That includes the use of adjunctive measures. Okay. That, maybe adjunctive measures would be like procedures that can be done on patients that have chronic pain. Okay, like TENS stimulation, epidural injections, that sort of thing. Okay, let's see next. Okay, we don't need to know about clinical practice. Okay. All right. So some theories of pain. Okay. Go to my thing here. Okay. So my slides. So a definition of pain, we're going to do the definition of pain. We're going to go over the gate control theory. We're going to see the nursing applications of the gate control theory. Okay, like I said, why do we need to know about the gate control theory? So we can be able to do our nursing care appropriately. The pieces of pain theory, okay, and how endorphins come into play with the theory of pain and pain management. Okay. Next. Okay. So the definition of pain is a neurologic response to an unpleasant stimuli. Okay. That is the basic definition. Any unpleasant stimuli. Okay. Whether it be a cut or bruise, a trauma of some kind, just an unpleasant stimuli, the brain is going to respond to it. And how the brain responds to that unpleasant stimuli is called pain. Okay. The gate control, somebody has a question? Thought somebody had a question. Okay. The gate control theory of pain. Okay, so this is a theory of pain, okay, that kind of defines how pain happens, okay. It says the gate control theory, based on the gate control theory of pain, when the gate is open, the pain sensation is allowed through. When the gate is closed, the pain sensation is blocked, okay. Some stimuli other than pain can also pass through the same gate, such as nausea, itching, numbness, okay? These other stimuli that I just mentioned can also pass through this pain gate as well, in addition with pain, okay? So nausea, itching, numbness can also pass through these gates with pain. Okay, so that's the gate control theory. Let's see. All right, so this is adding on to the gate control theory. Okay, when a large volume of non-painful stimuli is competing for the gate, okay, non-painful stimuli will be what I just talked about, those stimuli, okay, that nausea, that itching, paresthesis, numbness, okay? When those non-painful stimuli is competing for that gate because they want to get through that pain gate too, just like pain does, okay? Pain impulses may be blocked, okay? When you're having that competition, when the pain impulses is having that competition for that gate, to get through that gate, okay, to get into the brain, to have the patient experience it, okay, the pain impulses may be blocked, okay. A high volume of pain, however, may override other stimuli and pass through the gate, causing the individual to perceive the pain, okay. So again, it's who wins, okay? If the pain wins, if the volume of pain is high enough, that pain is going to push itself through the gate and the patient's going to feel the pain, okay? If you have that non-painful stimuli, that itching, that nausea, that numbness, okay, if you have a large amount of those non-painful stimuli, they're going to get through the gate before pain does if their volume is large enough, okay? And it's going to block the patient from perceiving that pain, okay? Let's see, next, right? Nursing application of the gate control theory, okay? So we have two types of nerve fibers, small diameter and large diameter, okay? They both carry painful stimuli. The small diameter nerve fibers carry pain stimuli, and the large nerve fibers carry pain stimuli. Okay. Activity in the small diameter nerve fibers seems to open the gate and activity in the large diameter nerve fibers seems to close it. Okay, so the small diameter nerve fibers is going to open the gate, and the large diameter nerve fibers are going to close it. Okay, massage and vibration produce activity in the large diameter nerve fibers. Okay, so that's why we want to do massage therapy and that's why massage and vibration tends to help when painful stimuli comes aboard, because those large diameters are going to close that gate. Okay, those large diameter nerve fibers that massage and vibration produce is going to close that gate, and that pain's not going to be able to get through. Okay, so that's why massage and vibration are important. Okay, and help with pain management. Okay, high levels of sensory input create brainstem impulses that seem to close the gate. Okay, let's read that again. High levels of sensory input create brainstem impulses that seem to close the gate. This is also known as distraction techniques. Okay, you give a patient something else to focus on sometimes. Okay, sometimes, again, that high level of sensory input is going to compete with those pain impulses. Okay, not only are they going to compete, but those high levels of sensory input, those distraction techniques, okay, are going to close that pain gate and not only compete with that pain impulse, but they're going to shut them out altogether. Okay, they're going to shut that pain impulse from going in. So that is why distraction is also another good technique to use with somebody that's having pain issues. Okay, like I said, sometimes it works, sometimes it doesn't work. Okay, it says distraction in the form of activity or social interaction produces these brainstem impulses. Okay, an increase in anxiety seems to open the gate, and a decrease in anxiety seems to close it. Okay, so if you have anxiety, you have increased anxiety, it's going to open that gate for that pain impulse to go through. Okay, but if you manage that anxiety and you get that anxiety decreased, it's going to close that gate. Okay, and not allow that pain impulse to go through. So that is why when you're anxious, okay, when somebody is in a high level of anxiety, they may feel pain more so than somebody that's not as anxious. Okay, because that increase in anxiety is going to open those gates and let that pain go right through. Okay, decrease in anxiety is going to close the gates. Okay, the fear that pain will not be controlled may actually increase pain intensity. Of course, okay, that's going to cause somebody to become more anxious. Okay, fear is very relative to anxiety. Okay, so if you have that high fear, you're going to have that high anxiety open the pain gates. The pain's going to be felt more rapidly. Okay, knowing that pain can be or is being controlled may reduce the pain. Okay, it's going to make, if the patient knows that the pain can be reduced, it's going to make them less anxious. Okay, less anxious, decrease in anxiety is going to close that gate, and they're not going to feel that pain as much, or if anything, they may not feel it at all. Okay, so increased anxiety opens the gate, patient feels more pain. Decrease in anxiety closes the gate, The patient may feel less pain or may not feel the pain at all. Any questions? No questions? Okay. All right. Going back. Okay. Let's see, next. Somebody have a question? Okay. So this is the pieces of pain theory. Okay, so now we're going to talk about the pieces of pain theory. Okay. So this pain theory says the more intense the pain, the greater number of pieces. Okay. So therefore, a greater number of pieces of analgesia, of pain medicine, will be required to control the pain. Okay, so the pieces of pain theory says, okay, the more intense the pain, the more management that's going to be involved. Okay, the more analgesia that's going to need to be required. Okay, to take care of that pain. Okay, that is the pieces of pain theory. Okay, next, endorphins. Okay, so we're going to talk about endorphins and how that relates to pain. Okay, so endorphins is endogenous morphine. Okay, what does morphine do? It's a painkiller, it's a pain reliever. Okay, so endorphins is natural morphine that the body makes. Okay, think of it like that. So endorphins are natural morphine, can attach to pain receptors and block pain sensation. Okay, what is a way that you can get endorphins? You can type it in the chat or say.
Excitement, maybe?
Prescriptions.
Excitement.
Oh,
Okay.
excitement. Okay.
Who said, somebody said prescriptions?
I misunderstood.
Oh, okay.
Tired
Yeah,
dog.
like what? Yeah, so any kind of activity, any kind of positive excitement, okay, anything that's going to cause you happiness, okay, is going to increase endorphins. Exercise has been known to increase endorphins, okay. Sex has been known to increase endorphins, okay. So you participate in those activities, okay, you increase your natural morphine that your body produces, okay, and you can actually block the pain sensation. Okay, so sometimes some people, it can be as easy, like if somebody has a pain thing going on, okay, sometimes it can be just as easy as them just going outside and taking a little walk around the block, okay, and they feel much better, okay. Or it could maybe sit their grandkid, they may be feeling crappy all day long and being in pain all day long. And boy, those grandkids walk through the door and everything is beautiful. Okay. Everything, all the pain's gone all away. Okay. That relates to endorphins. Okay. Endorphins in relation to pain. Okay. All right. Let's see. Physical touch, Caitlin said physical touch like a hug. Absolutely. You know, any kind of positive reinforcement, any kind of thing, anything about positive increases the endorphins in the body. Okay. All right. They appear to modify and inhibit unpleasant stimuli, reduce anxiety, and relieve pain. Okay. Endorphins also may produce feelings of euphoria and well-being. What is euphoria?
Isn't it like a intense feeling of like happiness?
Yep. A high, Okay, like, oh, like you go outside, it's a beautiful day, you've been sitting inside all day long, and you go outside and the sky is bright blue, not a cloud in the sky, and you're like, oh God, this is beautiful. Okay. Again, wedding days. Okay. Well, depending. Okay. Wedding days can be a sense of euphoria for people. Having children, okay, birthing, the birth process can also cause senses of euphoria in some individuals. Okay. Like I have here, for example, the runner's high is believed to occur because endorphins are released after physical exercise. Okay. You hear about people talk about the runner's high. Okay. They run a race and you would think that they would be tired after they cross the finish line, and some of them they keep going, they keep running because they still have that high. Okay. They still have that runner's high. They have that release of endorphins. Okay. All right. All right. Next. Okay. So nociceptive pain. Okay. Nociceptiveness. So now we're going to be talking about the types of pain. Okay. So nociceptive pain, okay, is a type of pain that's associated with pain stimuli from either a somatic or visceral structure. Okay, somatic can be a body tissue, or visceral can be an organ structure. Okay, so an example of a body tissue would be a muscle. Okay, a bone. Yeah, a muscle or a bone would be an example of a body tissue. That's the ones I can think of off the top of my head. A visceral source would be kidney pain. Okay. Heart pain, chest pain, heart. Okay. Brain pain. Okay. A headache. Okay. Could be caused from something in the brain. Okay. Those are all visceral sources. Okay. GI tract, stomach pain. Okay. That is a visceral source. Okay. So anytime the pain comes from either a somatic, a body tissue, or a visceral source, that's going to be considered nociceptive pain. Okay. All right. Next. Okay. Somatic nociceptive pain. Okay, so nociceptive pain is going to be a pain that's coming from either a visceral source or a somatic source. It's going to be coming straight from an organ or straight from a body tissue. Somatic nociceptive pain arises from injury to tissues where pain receptors called nociceptors are located. Okay. So either on the organ or on the tissue, they will have these pain receptors on them. Okay. And when you have an impulse that hits those pain receptors, okay, that's going to be considered a somatic nociceptive pain. Okay. These nociceptors may be found in the skin, connective tissue, bones, joints, or muscles. Okay, as well as some organs. Okay, trauma, burns, or surgery may cause injuries triggering somatic nociceptive pain. Okay, so somatic nociceptive pain is when those pain receptors, okay, those nociceptors and pain receptors are the same thing. Okay, those pain receptors are engaged. Okay, from something, okay, from a trauma, from a burn, or from a surgery. Okay, that is going to cause somatic nociceptive pain. Okay, next, visceral nociceptive pain. Okay, visceral nociceptive pain arises from pathophysiology in visceral organs, such as the organs of the GI tract. When you see the word visceral, visceral equals organs. Okay, visceral equals organs. Okay, somatic is more tissue related. Okay, is more skeleton, muscle, connective tissue, okay, bones, okay, whereas visceral is going to be the actual organ that's causing the pain, okay, such as the GI tract, heart, kidney, uterus, okay, those are some common visceral nociceptive pain organs, okay, that can cause pain. And anything that's wrong with those organs, okay, a pathologic condition triggering visceral nociceptive pain includes tumors and obstructions of the organs. Okay, so you have a tumor in the lung. Okay, a tumor is a pathologic condition. Okay, that's triggering that visceral nociceptive pain. Okay, that tumor is something that's not supposed to be in the lungs. Okay, so it's causing the lungs to exhibit this pain because it's not supposed to be there. Okay, if you have an obstruction in the GI tract, okay, you have a GI obstruction. Okay, same thing, whether it be stool of is the obstruction, whether it be the tumor is the obstruction, okay, or sometimes it might be the bowel itself is an obstruction, because you'll learn about this next semester. Okay, sometimes the bowel can turn on itself and obstruct itself. Okay, so those would be some examples of pathologic conditions that would trigger visceral nociceptive pain. Okay. Any questions? No questions? Okay, moving on. Okay. Okay, 4 phases of nociceptive pain. Okay, so nociceptive pain, okay, is going to be that tissue pain, that bone pain, that muscle pain, okay, the skin pain, okay. So 4 phases of the nociceptive pain, okay, transduction, transmission, perception, and modulation, okay. Need you to know those 4 phases, okay, very, very important. Transduction begins when the tissue damage causes the release of substances that stimulate the nociceptors and initiates the sensation of pain. A lot of wording there, okay? Transduction is going to be your first phase, okay? The tissue gets damaged, okay? That tissue, that nociceptive, that somatic area gets damaged, that tissue gets damaged, okay? So in transduction, the tissue is damaged and that tissue is going to release substances, okay? That's going to stimulate those pain receptors and initiates the sensation of pain, okay? That's the first phase, okay? Transmission, okay, is going to be the movement of pain, of that pain sensation, okay, that is stimulated by the pain receptors, okay. So that pain is going to move to the spinal cord, okay. So transmission involves the movement of pain sensation to the spinal cord, okay. Perception occurs when the impulses reach the brain and the pain is recognized, okay? So the pain sensation travels along the spinal cord, and then bingo, it gets to the brain and it tells the brain, tell this person this hurts, okay? That's perception, okay? Modulation occurs when the neurons in the brain send signals back down the spinal cord by the release of neurotransmitters. Okay, so the brain comes on and it says, okay, I'm telling the patient this hurts. Okay, and then modulation kicks in because those cells and those neurons in the brain are going to send the signals back down to the spinal cord by the release of neurotransmitters. Okay, and it's going to affect, and then it's going to affect that particular tissue or organ that's being damaged. Okay, so transduction, okay, is the first phase. That's where the pain happens. That's the start of the pain. Okay, but the patient doesn't feel it until perception. Okay, that's when the patient feels it, the signal goes to the patient's brain and says, okay, this hurts. And then the pain actually the pain is actually felt in modulation. Okay, this all happens in a matter of like milliseconds. Okay, that all this happens. Transductions, transmission, perception, and modulation. Okay. So know those phases. Know those phases and know how they come in order. Okay, and know what they do. Okay. Any questions there? Okay, next. Nursing implications related to nociceptive pain. So what are we going to do as nurses, okay, to help with nociceptive pain? Okay, so we are going to treat the nociceptive pain, okay, maybe directed towards one or all of the 4 phases. Okay, so we may focus our treatment strictly in the modulation phase, or we may, the advanced practitioner or the MD may treat the nociceptive pain in the transmission phase. Okay, so it may be directed at one or it may be directed at all 4. Okay. Non-steroidal anti-inflammatory drugs, or NSAIDs, work by blocking the production of the substances that trigger the nociceptive, the nociceptors in the transduction phase. So NSAIDs, okay, non-steroidal anti-inflammatories, okay, Motrin's a big NSAID, Tylenol is a big NSAID, okay. Those are going to work, okay, by blocking the production of the substances that trigger the pain receptors. Okay, so that's going to happen in phase 1. So NSAIDs are going to happen in phase 1. Okay, they're going to stop that nociceptor from they're going to block that those substances that are released in a traumatic situation that is going to trigger the pain receptors. Okay, so that's what NSAIDs do. It's trying to block that chemical response that's going to trigger the pain receptors. Okay, opioids, okay, painkillers. Okay, opioids are going to be your Demerols, your morphines, your Percocets, your Loratabs. Okay, those are going to interfere with the transmission phase. Okay, those are going to stop the impulses from going to the spinal cord in the transmission phase. Drugs that block the neurotransmitter uptake work in the modulation stage. Okay, so the modulation stage is when the patient actually feels the pain. Okay, so they may give drugs that may block that neurotransmitter uptake so that the patient doesn't physically feel that pain. And that happens in the modulation stage. Okay, so those are some treatments related to the different phases of pain. Okay, and how they work. Any questions? Okay, so if I were to ask you a question that said, which phase do NSAIDs work? The transmission, transduction, modulation, or perception phase? What would you say?
Transduction.
Transduction.
Transduction. Okay, NSAIDs work in transduction. Okay, so that's how I'm going to kind of present that to you on exam. Okay. All right. Next. Non-pharmacologic treatments such as distraction and guided imagery may be affected during the perception phase. Okay. Perception phase is when those impulses go to the brain and tell the patient this hurts. Okay. Those non-pharmacologic treatments, distraction and guided imagery, okay, is going to stop that impulse from going to the brain, telling the patient that it hurts. Okay. So distraction, guided imagery, yoga, those types of things help during the perception phase of pain. Okay. Next. Okay, so neuropathic pain, okay. This is another type of pain, okay, that's associated with a dysfunction of the nervous system that involves an abnormality in the processing of sensations. Okay, so this is a pain that comes from a nervous place, okay. It lives in the nervous system, okay. So it's some kind of dysfunction that's happening in the nervous system that's causing this pain, okay? These dysfunctions in the nervous system are often associated with medical conditions rather than tissue damage, okay? So this is going to be more condition-based, like hypertension, diabetes, myasthenia gravis, okay? Those are all medical conditions, okay, rather than the trauma itself, okay? So neuropathic pain is going to come more from medical conditions than actual tissue damage, than physical tissue damage, okay? Neuropathic pain may be the result of damage to the nerve roots, such as compression or entrapment. Okay, so neuropathic pain, like I said, most of the time are going to be from specific medical conditions. Okay, but they can happen. Neuropathic pain can also happen when some kind of damage is done to the nervous system in general. Okay, such as if you have a tumor compressing on that nerve, okay, that can cause neuropathic pain, okay. Or if you have a lot of people that have you hear about slip disc, okay, in the back, okay, that's an example of damage to the spinal cord, okay, in the spinal column that can cause neuropathic pain. Okay, the disc is slipped, it's not in the right place, okay, so it's going to cause some damage, okay, and it's going to cause that neuropathic pain. Okay, next, let's see how we're doing. 46. Okay. The pain signal that would normally move from the periphery towards the brain reverses, and the signal is sent in the opposite direction. This is what happens in neuropathic pain. Okay. So again, that's a lot of words. Let's break it down again. The pain signal that would normally move from the periphery. So the periphery is like your fingers and your toes, the out part of the body, okay, the fingers and the toes, okay, it reverses in neuropathic pain, okay, so the signal is sent from the inside to the out in neuropathic pain, okay, Normally, it's going to be the out in from the periphery. So the senses is going to come from the periphery and it's going to move inside. However, in neuropathic pain, it's the opposite. It's going to move from in to out. Okay. An example is phantom pain of neuropathic pain, a pain felt in a limb after an amputation. Okay. Would arthritis, let's see, Emily Smith said, would arthritis be neuropathic? That's a good question because arthritis is a joint inflammation process. Not really sure, Emily. I'll have to look into that one. Okay. Because it's coming from an actual source, an inflammation source, and it's not really nerve related. Okay. I would be more inclined to say it would be a more type on the more somatic or nociceptive side rather than neuropathic. Okay. Emily Watson said, wouldn't that depend on where the arthritis is? Again, but arthritis itself is an inflammation. Okay, so inflammation is more of a tissue trauma situation. Okay, so that's why I'm more inclined to say that it would be more of a nociceptive versus a neuropathic path. Okay, but I'll check into that more. Okay. All right. Now nerve damage itself, okay, would be more on the neuropathic side. Okay, because, you know, let's go back to the few slides. Okay. So nerve pain, let's see, neuropathic would be, you know, it's a dysfunction of the nervous system that involves an abnormality in the processing of sensations. So neuropathic pain is going to be neuro-based. Okay, it's going to be something that involves an abnormality in the neurosystem. Arthritis is more along the lines of an inflammatory process. Okay, so like I said, that's why I'm more inclined to say it would be more of a nociceptive pain than a neuropathic pain. I'll look more into that. Okay, nociceptive versus neuropathic. Okay. Good question. Very good question. Okay. All right, so let's go back to the next slide. Okay. Let's see. So nursing implications related to neuropathic pain. Okay, so what are we going to do as nurses for neuropathic pain? Okay. Analgesics and opioids usually do not relieve neuropathic pain. Okay. Very, very important statement there. Analgesics and opioids usually do not relieve neuropathic pain. Okay. Because analgesics and opioids are normally going to be working on the tissue. Okay. The tissue themselves that's being damaged, okay, and the perception and modulation phase, okay. So it's not going to help relieve neuropathic pain. You have to get down to relieve the neuropathic pain, to really help with the neuropathic pain. You really have to get down to the neuro level and the nerve cell level to get that pain to be manageable. Okay. Adjuvant medicines, extra medicines such as NSAIDs, tricyclic antidepressants, anticonvulsants, and corticosteroids relieve neuropathic pain. Okay. So those are some medicines in addition to that nerve therapy. okay, to getting to that nerve cellular level, okay? These would be some other medications that would help to relieve that neuropathic pain, okay? But the primary in neuropathic pain, okay, your primary treatment, I guess you'd say, would be something that is going to get to that neuro level, such as stimulation, okay, surgery. Surgery would be more of a extreme measure, okay, but it would have to be a little bit more mechanical to really get to the neuropathic pain, okay, whereas nociceptive pain can normally be relieved by little less mechanical measures. Neuropathic pain is going to be a little bit more complex. Okay, any questions? Okay, all right. Next. Okay, perception of pain. Pain is a subjective experience. Okay, so, and you'll learn this in pharmacology too with Miss Traylor. Okay, so pain is going to be different for everybody. Okay, so it's a totally subjective experience. That is why it is sometimes can be a very hard thing to treat. Okay, because it's pretty much different for every single person. Okay, one patient's pain level of 10 can be another patient's pain level of 2. Okay, it's all subjective. Okay, that's why when you do a pain assessment on a patient, okay, you just can't look at a patient and tell that they're in pain. Okay, you have got to ask them, what is their perception of pain? Okay, I like to use a 0 to 10 scale. Okay, I think that's the most objective measure to measure a subjective experience. Okay, you ask the patient, what on a scale of 0 to 10, 10 being the worst pain you've ever had in your entire life, what would you say your pain is right now? Okay, that's how I assess pain. Okay, that is how I do it. Okay, that way it'll give that patient a moment to think about it and say, okay, what's the worst pain I've ever had, and what is my pain right now in relation to that particular experience? Okay, subjective experience. Okay, do one more slide. Let's see. Okay, so pain threshold. Okay, we're going to talk about pain threshold and then we're going to stop. Pain threshold is the point at which pain is perceived. Okay, you hear people say, I have a high tolerance for pain. Okay, tolerance and threshold kind of go hand in hand. Okay, if a patient says I have a high tolerance, okay, that normally means they can take more pain. They can tolerate more pain. Their threshold is higher. Okay. Relaxation and distraction strategies can alter the perception of pain. Okay. So again, we talked about that gate theory. Okay. That gate control theory. You get that mind working on something else, it competes with those pain impulses. Okay, and those relaxation and those distraction strategies also close that pain gate. So not only do they compete with pain, okay, to get through that door, but these relaxation and distraction strategies are going to close that door completely and not let that pain get in at all. Okay, so that's why relaxation and distraction strategies can help and alter the perception of pain and increase a patient's threshold. Okay, so it would take more for this patient. If a patient has a high threshold or a high tolerance, okay, it would take more pain impulses for the patient to be able to perceive it. Okay, any questions, any issues on what I've discussed today or in the future? Okay, going through. Okay, guys, so if there's no other questions, I will let you guys go. I will see you tomorrow. I'm still working on sim stuff for Thursday and Friday, but I will have a definite answer for you guys tomorrow about that and what to do with that. So if that's it, y'all have a great day and I will see y'all tomorrow.